TAVI or TAVR is minimalistic approach to replace heart valve, that is aortic valve. 2 decades before, this valve replacement was a major surgery, so in which we have to give general anesthesia to patient and then cut open the chest and then stop the heart and send all the circulation onto cardiopulmonary bypass and then open the heart and remove the old valve and replace it with new valve. But today, so with the technological evolution, we don't need to do all these steps to replace aortic valve for a patient. So we can do entire valve replacement in a minimalistic invasive approach with a 2 mm hole in the patient's groin without any anesthesia, without opening of chest and without stopping heart. So that procedure is known as TAVI or TAVR. So this decision of TAVI on a patient with aortic valve disease is reviewed by a heart team in the hospital, so which constitutes myself and a cardiac surgeon and cardiac anesthetist. All of us sit together and discuss about patient's problem, and then we do a test known as CT, cardiac CT, in which we assess complete structure of the valve and heart and aorta, and we take all the necessary dimensions related to this procedure. Based on that, we decide, we calculate the risk of surgery, risk of TAVI on the patients, and then we take a decision on TAVI. So for this procedure, planning is the key. So the pre-procedure planning, every step in surgery is defined before based on the dimensions of the CT. And we go into theater and just execute the plan and come out. So when planning is perfect, most often this procedure goes flawless. So during procedure, the first step in this patient is preparing an access to send the valve for deployment. So usually we don't give general anesthesia to these patients. It's only conscious sedation. Patient will be conscious throughout. We keep speaking to patient in between. What we do is we give anesthesia to both groins of the patient. We give infiltrative anesthesia to both groins, and then we start procedure. So we puncture the groin artery through which we send valve. Before, we used to open entire groin to identify artery and create an opening, but there is no need to do that now. So it's all minimalistic. We use certain pre-closure devices after puncture so that we can close the rent in the artery after procedure. We use 2 pre-closure devices, and then we place a sheath inside the groin artery for further procedure. This plays a key role because the commonest complications after this procedure is vascular complications, so which we can nullify by careful analysis of CT and careful puncture and placing proglides in a right place. So after achieving access through the groin artery, we place a sheath, 16 French sheath. So that means it's almost of more than 5 millimeters in size. We place that sheath through that artery into the aorta. That's a main vessel of the body. So that is the reason we do CT to assess the artery size. Whichever the artery allows this size sheath, that artery axis we take. If it is right, left, sometimes if it doesn't allow, we may take other arteries like axillary artery or sometimes even carotid artery. So the size of the artery is very important. So once sheath is placed into the aorta, then we position a temporary pacemaker so through the right femoral vein into the right side of the heart, that is right ventricle. This temporary pacemaker is again very important because sometimes when we place this valve, few patients may go into a kind of low heart rate situation. So they go into heart block, so their heart rate drops down. If you have a temporary pacemaker there, so that counters that problem which may arise due to heart valve deployment. Another thing is, to deploy valve also, we have to reduce the patient pressure. To reduce patient pressure, we basically increase patient's heart rate by using pacemaker to 160 or 180. So that is the reason pacemaker is positioned for these patients. After that, so we take a catheter to cross the valve. We cross valve with different techniques, and once valve is crossed, we place a pigtail in left ventricle, and then we assess the pressures in the left ventricle and aorta. So, and we assess the pressure difference between these two chambers, so that post valve replacement, again we can understand those hemodynamics and the difference which we made from before and after, and also to understand sometimes leaking of these valves. So once these pressures are measured, then we'll take an appropriate balloon to dilate the valve. So usually we take a balloon which is less than the size of the valve which we are going to use. Say for example, if it is a 23 mm valve, we use a 20 balloon. If it is 26, we use 23 balloon. So we take a balloon, we'll keep it across the valve and you dilate the balloon so that you are creating a space for the valve to follow next. And after dilatation, we remove the balloon. We take valve inside, and this valve is positioned slowly into the final position where we have to deploy using a particular delivery system. Once the valve is positioned perfectly in fluoro, we take repeated injections to confirm the position, and once position is confirmed, we deploy the valve in that position. So, and this deployment it's a quick procedure. After deployment, we take out the balloon and assess the expansion of the valve and function of the valve by fluoroscopy and echocardiography and pressure differences between the left ventricle and aorta. With these methods, we assess how well valve is expanded and how it is closing and opening, and are there any leaks in this valve. So if everything is fine, so we'll take out all the system, and we also assess, is there any problem in heart rate, whether the heart rate is same or it's reduced. If the heart rate is reduced, that says mostly that valve is causing a heart block, and that patient may need pacemaker subsequently. If the heart rate is not reduced, we just remove pacemaker also. So once we confirm the valve function is pretty okay, in echocardiography and fluoroscopy and angio and with hemodynamic assessment. We remove balloons and temporary pacemaker and all the wires which we placed in heart. Then we come to the access site closure. So the rent which we created in the artery, the access artery, we have to assess with angiography. If we have created any trouble in the vessel, sometimes we may lacerate vessel. So if any such problem occurred, immediately we have to address that problem by placing some stent grafts. If there is no such problem, we close the rent with the sutures which were placed in the beginning. And that completes the entire procedure of TAVR. Post procedure, we talk to patient on table and then we shift the patient to ICU, where we keep them under observation for next 24 hours to mainly observe for any complications related to the groin or complications related to heart blocks or sometimes brain strokes. So we observe them for 24 hours for any issues. If there are no issues, then we shift them to room and we subsequently discharge them on third or fourth day. If there are any issues related to these things, that may delay discharge based on the further therapy of the patient. So post discharge, patient can do all the activities which he was doing before. Not much of limitation. In fact, whatever functional limitation they had before valve surgery will actually get reduced, and they can definitely do better functionally. They can do all the activities which physically they can perform. And regarding diet and all, usually we advise them salt restricted diet and other diet related to other ailments at that age.